Garbage bin.
So like all the meat?
Food.
Oh.
I'll eat it.
Oh.
We should get him something called a garbage bin.
Yeah.
All right, let's go ahead and get started. Good morning, everyone. Welcome to Grand Rounds. It's really my honor to introduce our speaker this morning, who really needs no introduction. But Dr. Williams will be speaking to us this morning. He is a Bills fan.
Bills fan, first and
Big
foremost.
Bills fan, a father of two children and a husband, and is also our program director, as we all know, and has been with us since 2006. Prior to that, he did his undergraduate education at Dartmouth and then went to Columbia for medical school. Came to Northwestern for his residency and then joined us here at University of Wisconsin in 2006, where he's been since. And we're really excited to learn about the office evaluation of the fertile male. And take it away, Dr. Williams.
Great. Thanks so much, Kyle. Appreciate the introduction. Good morning, everybody. Wanted to make sure that we did a quick check of that title, Office Evaluation of the Fertile Male. So since it was on the email and it was on the docket, theoretically, that's what I'm supposed to be talking about, but there was a major typo. So the focus of this is not my vasectomy talk. This is my anti-vasectomy talk, meaning if a couple's coming in, they're having trouble getting pregnant, we're going to talk today about how do we take a look at the male partner to see if there are any male factor issues. So office evaluation of the infertile male. Sorry to disappoint if people were thinking that we're going to be talking about the fertile male. All right, with that being said, nothing to disclose for today's talk. So about 7 or 8 years ago, the word infertility, the nomenclature changed, and the definition became that infertility is actually a disease. So why was that important? Well, there continues to be a lot of debate about fertility coverage by insurance companies, both at the state level and then also at the federal level when you get into things like Medicare and VA coverage. Is fertility a disease? Yes, it's been renamed a disease. And when you think of what is a disease, it's any deviation from the interruption of the normal structure or function of any part, organ, or system of the body as manifested by characteristic symptoms and signs. Etiology, pathology, prognosis may be known or unknown. So if you think of infertility, that does fit into the definition of a disease. So that's an important thing to keep thinking about. It's not just, oh, we're trying to get pregnant and yeah, we're struggling. It's a deviation from the normal expected course. And with that, there are some important things we're going to be talking about to potentially identify when you're taking a look at that male partner. Multiple definitions of what is infertility, but the most widely accepted is failure to achieve a successful pregnancy after a year or more of appropriate time to intercourse. And there are some exceptions to that we'll touch on as well. So even though the textbook would say, yeah, if the couple's been trying for a year, then take a look at them and avoid taking a look at the infertile couple beforehand. Well, if it can be a couple can be evaluated in a shorter period of time if there are potentially known risk factors, something in the patient's medical history, the male or female partner's medical history or physical findings that might warrant an earlier examination and evaluation, or in the setting of advanced maternal age. So if the female partner is over 35, it is recommended to take a look at that couple sooner rather than later, because sometimes when things are identified on both the male and female sides, or male or female sides, it can take some time to address that, and you want to know that earlier rather than later when you're talking about advanced parental age. Or if a man presents and says, I'm just concerned about my future fertility, sure, that can trigger an evaluation if the man desires that. So how big of a concern is this? Well, about 10 years ago, when the CDC did a survey of family growth, there were about 6 million couples in the US with fertility at that point. And that essentially represented about 10% of the reproductive age population. So even though 10% is a relatively low number, 10% of a large number is a lot of people who are faced with that. And at that time, it was about a little over 1 million women made new office visits to the provider for an infertility evaluation. But for the purpose of this focus, what was notable was that only about 20% of the male partners of those women actually received a medical evaluation for infertility. Now, there's certainly a number of different reasons why that may be the case. Certainly, there's a notion out there in the medical and the general population that the problem is usually due to the female partner. But similarly, many urologists are not all that interested in evaluating the male partner or specifically trained to identify or care for those male factor issues when they're identified. But when you really look at the breakdown, yes, about half the time there's a female factor only that's contributing to an infertile couple's issues. But about a third of the time, there's solely a male factor, and the other 20% of the time, they're combined both male and female factors. So about half the time, there is a male factor that's either contributing or the sole factor in that couple's infertility. Again, just underscoring the importance of taking a look at that male partner of the infertile couple. So why do we take a look at the man? Well, we want to identify, are there potentially correctable conditions that we as urologists can potentially treat? The goal there to allow for conception through intercourse and utilizing assisted reproductive techniques only when necessary. So 3 examples I just kind of threw up there. One would be medical management. Sometimes you may identify a severe pituitary abnormality, and you can actually help that man out with certain medications. The picture in the middle, sorry, I know it's early, but had to put the picture up there to wake everybody up. That's a varicocele, which we'll talk about in a little bit. And when can we do microsurgical reconstructions? If a man has idiopathic epididymal obstruction, we can do epididymovasostomy to allow a man from azoospermia to potentially being fertile. Similarly, when we're evaluating the male partner, we want to see, is there something going on that we can identify, but that we cannot improve upon, where that man just has a low sperm count or poor quality sperm that we cannot treat, but that we can use his sperm with assisted reproductive technologies. That's also an important thing. We also want to see, are there conditions that man has where we can't even use assisted reproductive technologies? There may be such a severe male factor going on that we cannot use insemination, we cannot use in vitro fertilization. And at that point, the conversation shifts to how to help this couple build their family and using other techniques such as donor insemination and adoption to build the family. And the idea of that is you're sparing the couples the distress, time, and cost of attempting ineffective techniques. Fortunately, more and more we're seeing fewer of these stories, but in the past, sure, there were many stories or many times where couples would come in, the couple had been evaluated by their provider, placed on a medication, or said, "Oh, go keep trying, you'll be fine." And then many months or even years, multiple years down the road, then the man gets evaluated and found to have a severe issue. And that couple just lost a large window of time and potentially lots of costs of, again, attempting ineffective therapies. Lastly, and even though this is rare, a handful of times per year when we evaluate the male partner, we will find a real health threat in that man that's underlying his infertility. So pituitary tumors and testicular cancer. So when Tom Walsh was a fellow at UCSF, one of his big projects was to review the SEER database in California. And essentially what he found in his review was that the testicular cancer was about 3 times more likely to develop in infertile men compared to fertile male cohorts. And that really helped to start identify that, yes, it's not just, oh, are you trying to get pregnant, that there may be potentially a significant underlying health issue that's either affecting or potentially going to be developing following the infertility diagnosis. Another thing that was interesting, the Walsh's group, when again at UCSF, during that review, they also found that when they looked at the cohorts of infertile men and then followed those men over time, those men were about 2 to 3 times more likely to, in the future, develop high-grade prostate cancer. So this also was a very interesting finding, and then kind of triggered the thought that, yeah, when you're evaluating that infertile male, not only are you going to use that as an opportunity to evaluate him right then and there, but also to counsel him about being aware of future health risks that may be associated with the condition that he's presenting with. So once that man is in front of you in the clinic, that couple is in front of you in the clinic, What are the different things we do? So like any medical surgical condition, we've got to take a focused history, do focused physical examination, know when and what tests to order up for that patient. And we'll go over some of these items step by step. Busy slide, not going to touch on all these, but essentially when you're seeing that infertile male, there are a number of questions that you want to ask, going from basic to a little more in depth. It's important to just ask them the basic questions. Are you having intercourse? If yes, when are you having intercourse? Do you all know if and when you're actually ovulating? And sometimes just even some of those basic questions can help you guide that couple to their fertility issues. But getting a little more in depth, to that male partner, does that man have any active medical issues, any past medical issues, past surgeries that might be affecting their fertility? What medications, if any, is he taking? Is he taking a medication that may have a gonadotoxic impact or something that will knock down his hypothalamic pituitary gonadal axis? And then just the last bullet point, for previous fertility does not exclude the possibility of a newly acquired fertility issue. So if that man comes in and says, well, yeah, I've had X number of pregnancies already, I'm fine. Maybe he is, but you still need to take a look at him because things can develop over time, as we know. So if that man has primary infertility or secondary infertility, the approach to that evaluation is still the same. Physical examination. So I'm talking to a group of urologists. So the focused genitourinary examination is a really, really critical part of the workup of the infertile male. Those of you who spent some time over at the Generations Fertility Clinic with me, where the women are also being evaluated, the initial evaluation on the female side is just an office discussion. There's not a physical examination that's a routine part of the initial evaluation of the female partner. They'll talk about things. They'll say, yeah, why don't we do some of these blood tests? Maybe we'll get you set up for some imaging studies. But for us, as people who are going to be evaluating the male partner, the physical examination is critical. So you want to do a good examination to see, what is the location of the urethral meatus? Does the man have a severe hypospadias? Maybe that man had not had good access to medical care throughout his life and never was diagnosed with a severe hypospadias. Does he have both testes? Is one testis bigger or smaller than the other? What is the consistency of the testes? Are the vas present? Is there unilateral absence of the vas? Bilateral absence? Unilateral absence of the vas should make you think about ipsilateral renal agenesis. Look at the secondary sex characteristics. The digital rectal examination, controversial, right? There's some dogma out there that if a male walks into the urology clinic, he's not leaving the office without a digital rectal exam. I've heard that said at many discussions. The way I look at it is, sure, if a digital rectal examination is indicated for that man, does he also have urinary symptoms? Is he of prostate cancer screening age and he hasn't had proper prostate cancer screening? Sure, do that digital rectal examination. Are you going to find something on digital rectal examination that's going to be the clear cause of their infertility? Probably not. But again, not only is he a man there for a fertility evaluation, he's also there for his urologic care. So when we move into testing, so at the bare minimum, when the couple's presenting for fertility evaluation, the man should have some sort of reproductive history taken. Could that be done by any provider? Could be, but medical and reproductive health history and an initial semen analysis. So if that semen analysis is abnormal, that should then trigger a more formal evaluation by a reproductive specialist. So with the semen analysis, again, that's generally the first test that's done. Sometimes it's covered by insurance, sometimes it's not. Over at our fertility clinic, there are some flexible collection times. In general, they like to do those tests in the morning rather than the afternoon because it can sometimes take a couple hours to process. And in some exceptions, the clinic can be open on the weekends for a weekend evaluation. The picture there is one of our private collection rooms at the fertility clinic. There are two of them there, and for some couples, especially those who live a far distance from the clinic, it's important to have a comfortable place for a man to do a semen analysis if they're coming in from at least an hour away. So semen analysis, you get a report back from the lab. How do you interpret it? It can be very confusing. So that's why I put that little cartoon in there. And so it's really not the question of, is my semen analysis normal, is it adequate for pregnancy? So there are many papers, as you might imagine, that have been published about the controversies of the World Health Organization reference range for semen analysis. I think it's good to have some working knowledge of what these ranges are, but essentially what the World Health Organization did a little over 10 years ago is they compiled many studies from all around the world of fertile men who had volunteered to give semen samples, and they came up with a bell curve and a distribution. They essentially took they did 2 standard deviations below the mean for these different areas and drew the line there, and they said, this is our reference range. So if you think about it, 2 standard deviations below the mean is essentially the lowest, about 6th to 7th percentile of fertile men. So part of the challenge is when you look at these numbers, in their studies, men below these numbers, those were still men who had fathered children. And in contrast, if you have a man who's being evaluated for fertility, just because that man is above the reference range, that doesn't necessarily guarantee fertility either. In our lab's semen analysis reports, we also have our lab report the World Health Organization 50th percentile. So for example, if you look at sperm density, sperm concentration of 15 million per milliliter, the average sperm concentration is 73 million per milliliter. And if a man has a sperm count of 17, 18, 19 million, he may posture up and say, well, I'm okay, my numbers are good, see right here, I'm fine. But if you then have that 50th percentile, that gives him a reference point to say, well, okay, maybe I might be above that minimum, but I'm kind of in that low normal range. Maybe there is something we can still do to try to boost my numbers to improve our chances of conceiving. Similarly, motility of the sperm of 40%, the average percentile is 61%. So if that man is 41, 42%, maybe there's still some room to potentially boost those numbers up more into the normal range. So the interpretation of the semen analysis can sometimes be challenging, both for the individual provider, but also counseling the couple about what those numbers actually mean. So then you're sitting in front of your Epic computer platform, and you've got all these potential tests that you could order up for that infertile couple, so for infertile male rather. So when do you check the hormones? So on the one hand, there's some experts across the country that think that any man who's presenting for a fertility evaluation warrants an endocrine evaluation. Sure, maybe. But when you really need to make sure that you evaluate the endocrine axis for that man is when he has a low sperm count. So oligospermia is the term for a low sperm count. When the sperm concentration in particular is less than 10 million per milliliter, that increases the chance that you may find an endocrinopathy that's contributing to that man's fertility issue. If there are other symptoms of a hypogonadal state, impaired sexual function, gynecomastia, et cetera, that should also prompt a hormone evaluation. So there's really no established consensus, but for sure, if that man has a low sperm count, want to make sure that you check some hormones. What hormones do you check? So this is the slide that I know I've reviewed with a number of the residents over time. If you have a good understanding of that little diagram on the right, that can get you a lot of mileage in taking care of your patients and understanding the negative feedback loops in the endocrine system. At the very least, if that man has a low sperm count, you got to check an FSH and testosterone. That can really help assess the gonadal status. Is the FSH normal, suggesting normal sperm production? Is the FSH elevated, suggesting a problem with testicular production of sperm? Is the testosterone normal or low? And then those other labs, those should really be prompted to be checked if that testosterone is low. So there's a whole other algorithm for the evaluation of low testosterone. That includes checking the LH and the prolactin to see if there is a secondary or primary hypogonadism issue. And then estradiol. Testosterone gets converted to estradiol in the adipose tissue. We're in a part of the country where there seems to be higher BMIs than other parts of the country. So some men do convert too much testosterone to estradiol. If you think again of the negative feedback loops, high levels of estradiol can suppress the hypothalamic pituitary gonadal axis. And so consider doing the estradiol in addition to testosterone, particularly if that man is overweight. Genetic testing. This is also an important concept to keep in mind about when to do genetic testing in men during the workup and which ones to check. So the way I have it kind of listed on the screen, I have them intentionally bundled so that the karyotype and the Y chromosome analysis, those should be kind of linked together. And when you're thinking about if I need to check those, and then the cystic fibrosis testing is its separate category. So if a man has a severely low sperm count, so I mentioned the term oligospermia, less than 10 million. If it's severely low, so severe oligospermia in the very low single-digit million per milliliter, that should trigger you to check a karyotype and a Y chromosome microdeletion. There can be chromosome abnormalities, chromosome duplications, Klinefelters, balanced translocations that can be found in the karyotype. And there can be certain areas of the Y chromosome specifically that have been shown to harbor genes involved with spermatogenesis. So if you're going to be thinking, oh yeah, okay, I think this guy's got a really low sperm count, okay, I should check the karyotype. You got to bundle in the karyotype and the Y chromosome microdeletion analysis, and that can oftentimes give you some answers about why that man has a low sperm count. In the setting of severe oligospermia or azoospermia due to a sperm production problem, about 15, maybe 20% of the time, you'll find a genetic abnormality. And even though that, again, is relatively low, if you find a genetic abnormality that's the cause of their low sperm count, that can be very helpful in counseling the couple, answering questions for them. A lot of times men in the couple want to know, why is my sperm count so low? If you have an answer, that can very oftentimes be helpful. And it can also help you with treatment planning. And for example, if there is a Y chromosome abnormality that's identified, but that man does still have some sperm in the semen, and that sperm could potentially be used for something like in vitro fertilization, you got to link them up with a genetics counselor and talk to them about the nuances of potentially passing on genes to their offspring. And ultimately, that couple needs to make a decision. Do I want to pass those genes on to my offspring or do I not? And so that's a very important part of the counseling process for these couples. In contrast, cystic fibrosis testing. So think of the difference between the two categories as a production problem versus a blockage. So if there's a production problem, you got to do the karyotype and the Y chromosome. In contrast, if there's a blockage that you identify in the male reproductive tract, ejaculatory duct obstruction, absence of the vas deferens, not unilateral absence of the vas deferens, but bilateral absence of the vas deferens, those types of obstructive abnormalities in the reproductive tract have been associated with CFTR abnormalities. So that's also very important. There are over 1,000 genes on the CFTR region that can be identified, and sometimes it's the less common CFTR abnormalities and ones that have less of a severe phenotype that are associated with these obstructive issues. So a man may not necessarily walk in the door with active cystic fibrosis, and you say, oh yeah, that you have absent vas deferens. The man may be an otherwise relatively healthy man, and you might be the first provider to identify that he's a carrier of CFTR abnormalities. So if there's a blockage in the reproductive tract, that should trigger you to think about CF testing. Ultrasounds. We use a lot of ultrasounds in urology. So when is a scrotal ultrasound indicated? Similar to hormone testing, some people say, well, every man who walks into the clinic, he should hop up on the table and do an ultrasound for him. You could take that approach. If you want to be a little more thoughtful about that approach, sure, just like in any man that we're evaluating in the urology clinic, if you're able to obtain a good, reliable physical examination of the testes, you probably don't need a scrotal ultrasound in everybody. If it's easy to palpate the testes, if the testes are normal, if they're smooth, there's no mass, you probably don't need a scrotal ultrasound. Everyone's anatomy is normal. Every man's comfort level in the office is different. So if a man has a challenging physical examination, tight scrotal skin, some men are very anxious during these fertility evaluations. I've had plenty of men vasovagal just in talking to them. If you can't get a good, reliable physical examination, or you're questioning your own physical examination, obtain a scrotal ultrasound. So you're looking for things like, testis masses, varicoceles potentially, especially if the man has very tight scrotal skin and you can't get a good look at that. Certainly if a man has risk factors for testicular cancer, maybe a history of cryptorchidism, and you don't get a good examination, want to think about getting the scrotal ultrasound. Overall, it's a relatively cost-effective test no ionizing radiation, pretty safe to the patient. Varicoceles, certainly a controversial area. We're not going to dive into varicoceles too much in this discussion. But in general, if a man is being evaluated for fertility and you do a scrotal ultrasound, most of the data support that if you see scrotal veins that are greater than 3 millimeters in diameter or reversal of flow when that man valsalvas, that has been shown to potentially adversely affect semen parameters. So this would just be an example before Valsalva, measuring about 3 millimeters in diameter. You ask the man to Valsalva, and you see reversal of flow seen with the power Doppler, and everything lights up. That's consistent with a clinically significant varicocele. Prostate ultrasound. As urologists, we're familiar with prostate ultrasounds for sure. Does every man need a prostate ultrasound? No. So who would benefit from a prostate ultrasound during a fertility evaluation? Think low volume ejaculate, right? The ejaculatory duct right in the middle of the prostate. And if there's a low volume ejaculate, and particularly if that man has a normal hormone panel, you got to start thinking about maybe a complete or a partial obstruction of the ejaculatory duct. So that would be an indication to check a prostate ultrasound. When you do that prostate ultrasound, what are you looking for? You're looking for midline cysts in the region of the ejaculatory duct. You're looking for calcifications in the region of the ejaculatory duct. And most of the data support that, sure, if there's a downstream obstruction, there's going to be some proximal dilatation. So the seminal vesicles you also look at very closely. When the seminal vesicles are dilated, greater than 15 millimeters, that suggests ejaculatory duct obstruction. The challenging ones to evaluate are men with potentially partial ejaculatory duct obstructions. Those men may have kind of low to low normal ejaculate volume. There may be some sperm in the semen. Oftentimes, those sperm that are present have very low motility. So those also can be evaluated with prostate ultrasound. Important to keep those in mind. All right, so it's been a couple years since the last opportunity I had to present to the group. So what's new in 2022? So at the end of 2020, COVID time, right? The AUA updated their guidelines in conjunction with the American Society for Reproductive Medicine. These are on the AUA website, and certainly if it's out there on the guidelines, it's something that we as urologists should have some working knowledge of. And I can go through some of the call it the highlights or lowlights maybe of the updated guidelines. So the previous guidelines were 2010, so fast forward 10 years. So I'm just going to call out just a handful of the new parts of the guidelines. So this was an interesting one. So in couples with who are undergoing advanced reproductive technologies, if couples are going through in vitro fertilization and they are not being successful, or they're having recurrent pregnancy losses, evaluation of the male should be considered. So what does that mean? So not every couple, as we've seen, who presents to a fertility clinic, does the male partner be evaluated. Sometimes the clinics will say, oh, you've got some sperm, you're not getting pregnant, off you go to in vitro fertilization, not evaluating the man. So if a couple does go through a number of cycles of something like IVF without success, and there's you're trying to think, okay, well, wait, this man has sperm, but why is this not working well? There are limitations of the standard semen analysis. Looking under a microscope, counting how many sperm are in there, are they moving? What do they grossly look like? And that's important, but that's not very, very specific about that sperm itself. So there are a number of different tests that we can do to do a deeper dive into the quality of the sperm. Sperm DNA fragmentation, looking at the karyotype of that man, checking for sperm chromosomal aneuploidy. Some sperm will carry abnormal numbers of chromosomes, and that's why when they fertilize the egg doesn't develop normally due to chromosome aneuploidy. So if there are situations like that, the man should be looked at. This was a big new section in the guidelines about lifestyle factors and relationships between infertility and general health. I'm going to go through each one of these because I think this is an important concept that who do we see in the clinic for male factor fertility evaluations? Generally younger men in their 20s and 30s for the most part. Are those men who are regularly going to the doctors? Not really, or to get regular checkups. So sometimes that man who's presenting for a fertility evaluation, sometimes that may be the first time that that man has seen a provider, maybe 10 years, maybe 20 years. So, sure, first and foremost, we're all providers and here to take care of patients. And even though we're specialists, sometimes when we're seeing this man for the first time, there may be an opportunity, a window of opportunity just to ask him about his overall health and counsel him about his future health. And that's what this section of the guidelines really highlights. So clinicians should counsel infertile men with or without abnormal semen parameters about health risks associated with sperm issues. So as we saw in some of those previous slides, abnormal semen parameters can be associated with future risk of testicular cancer. There are multiple studies that indicate increased risk of actually future mortality, as well as the Charleston Comorbidity Index scores being higher in men with abnormal semen parameters. So it's important to tell that man, hey, this may not be just a reproductive health issue. This may be a future overall health issue that you're looking at. We've talked about different potentially underlying causes of male infertility. I mentioned briefly Klinefelter syndrome, CF, cryptorchidism, testosterone deficiency. But if you identify any of these issues with the man, it's also important to counsel that man that not only do you have this condition, but those conditions are potentially associated with future issues. Many men with Klinefelters also have low testosterone. Many men with CFTR gene abnormalities, not only do they have pulmonary problems, they can have pancreatic deficiency, dental issues. We know that men with cryptorchidism histories can be at risk for future testicular cancer. And testosterone deficiency has been associated with a number of different issues in the future: diabetes, cardiovascular disease, metabolic syndrome. Interestingly, all-cause mortality and Alzheimer's are associated with testosterone deficiency. Clinicians should advise couples with advanced paternal age that there's an increased risk of adverse health outcomes for their offspring. So this was important, in my opinion, for that to be included in the new guidelines. The traditional thought is, oh, men are fertile throughout their lifespan, and think back to was it the Playboy Mansion guy, Hugh Hefner, right, having kids when he was in his 80s, right? Men are fine, everything's fine, right? No problems with the man. Well, there's plenty of data, and there's a growing body of data that with advanced paternal age, that there can be increased risks to the offspring. Germline mutations, sperm chromosomal aneuploidy, birth defects have been associated with advanced paternal age, and also neurocognitive issues such as schizophrenia and autism have clearly been associated with advanced paternal age. Very important to counsel that man in front of you in the clinic if he's presenting and is of advanced paternal age, that there are potential risks to the offspring that they should be aware of. Risk factors for male fertility can also be associated with risk factors for overall health. The data are a little bit mixed as far as these risk factors that I have listed. Do they definitely uniformly affect fertility or not? But it's important to counsel men that yes, obesity has been associated with lower semen parameters. Poor diets have been associated with impaired semen parameters. Smoking has definitely been associated with poor sperm quality and increased DNA fragmentation. Finasteride, which we as urologists prescribe a lot of, finasteride 5 milligrams, but not 1 milligram, can decrease semen volume. Exposures to pesticides and lead have also been associated with impaired fertility. So if there are things in that man's lifestyle that can be modified to potentially improve his overall health, his reproductive health, those can also improve his overall health as well. So again, that window of opportunity that we have to have that young man who hasn't seen a provider in many years, we can potentially affect his future overall health with proper counseling and identification of these risk factors. Last thing, I just wanted to highlight what's new in 2022. Sperm DNA fragmentation, which is a test that we do commonly order during the workup of male fertility. It's not recommended in the initial evaluation of the male fertility. So again, that initial evaluation, reproductive history, medical history, initial semen analysis, the DNA fragmentation is not part of that initial evaluation. But if you identify risk factors that might be concerning for sperm abnormalities, history of miscarriage, is the man a current smoker, is he older, Have they already failed IVF? That should trigger you to think about doing a deeper dive into the sperm quality evaluation for that male. All right, so a couple weeks ago when Jacob was presenting, I kind of started to give him a hard time about what is IVF, what is ICSI, what's this alphabet soup. All right, so here you go, Jacob. Here's intracytoplasmic sperm injection. So when I was a fellow at Baylor, Dory Lamb was the lab director. Dory's a very well-known researcher in the andrology world. She's a past president of the American Society for Reproductive Medicine. Everybody knows Dory. So Dory put together this video when I was a fellow of ICSI. So essentially what you do is when the sperm are in the lab, you can change the pH of the solution that they're sitting in, and that'll impair their motility. So you got to find a sperm. Those of you who've been in the OR with me and looked at the slides under the microscope, when those sperm are moving, they're moving. So you've got to stop the motility of the viable sperm, and then this is a micropipette, and you have to aspirate the sperm up into the micropipette. As fellows, we were never allowed to actually inject the sperm into the, there we go, one up into the pipette. We were never allowed to do this. You have to be a certified embryologist to legally manipulate the eggs and the sperm. But they let us play around with the micropipettes and aspirating the sperm, which was kind of a fun thing. But here we go. We're going to pierce the cytoplasmic membrane. You can see the sperm at the very tip of the micropipette. And once the membrane is pierced, then they inject the sperm directly into the cytoplasm. Right there, off it goes. And that is ICSI. So pretty cool technology. Like many major medical advances, this medical advance of ICSI was actually made by mistake. So then they also watch the embryos develop. There's the polar bodies you can see, and then they develop into different blasts as the cells develop, blastocytes. Yeah, so in the late 80s, when they were coming up with more the IVF and the ICSI process, at Columbia University, the lab technicians were trying to figure out what's the best way to inject the sperm into the eggs. And the thought back then was that you had to inject the sperm directly under the zona pellucida, and it was not supposed to be penetrating the cellular membrane. So the story was that the first lab technician who slipped and who by mistake injected the sperm into the cytoplasm was immediately fired, had their license revoked. They could never be involved in embryology ever again. Turns out that's exactly what you're supposed to do to optimize pregnancy. But so again, there are many stories like that in the medical surgical world history. All right, so in the home stretch. So when we're seeing patients in the male fertility clinic, and you start thinking about, okay, there's a patient in front of me with some male fertility issues. What are we going to be looking for? What are we going to be finding? So this was from the last edition of the male fertility textbook. What I wanted to highlight here is that there are a number of different conditions that we can identify that can potentially contribute to male fertility issues. But the number one most common diagnosis remains unexplained. And that is an important thing to keep in mind, and something that I routinely counsel couples about, that even though the majority of the time we can find things that can explain why you're in your situation, or we can find things that we can potentially treat to improve your situation, about a third of the time, we're all left scratching our heads as to why that man may have issues with the sperm production or sperm quality. So important to keep in mind. So with that being said, I'm going to leave this on the slide just as we wrap up here. Thanks for your attention. Please make sure that you have access to these guidelines. They're very useful if you're going to be evaluating the male partner of an infertile couple. And last time I checked, I think our resident team have a little quiz coming up next month. So these can be very useful for your review and preparation. So thanks for your attention. Happy to field some questions. Yeah, Kyle's got a mic there for you. And there's also one with the residents, I believe.
Yeah, sure. Any questions from the group? Jeremy.
Hey, thanks for the talk, Dr. Williams. I just had a question about the you had mentioned one of the guidelines, I think it was expert opinion about advanced paternal age as a factor. Is that something that has a linear correlation? Like, is there a difference between a 60-year-old male and a 40-year-old male? And then, since it's expert opinion, I mean, how strong of a, how do you counsel, like a gentleman comes in, he's 40 years old versus, someone 70, let's just say. How do you explain that to them?
Yeah, it's a great question about kind of the definition of advanced paternal age and the severity of that effect, right? And so there is a lot of controversy about at what age should a man be considered quote advanced paternal age. Very similarly on the female side, is advanced maternal age always 35 or over? Is it 40 or over? There's so much individual variability about fertility potential on both the male and the female side that there's not like a hard and fast rule about that. But I think the most important concept is that you identify to that man that there are reproductive risks, especially to the offspring, when that man is older as opposed to younger. Your question about is there a linear correlation? I don't think that that's been determined. That there's a direct, that 50-year-old is twice as much, and then 60-year-old 3 or 4 times as much. But if that man is older, you need to counsel him about that, and you need to consider some of those other sperm quality testings that have been associated with advanced paternal age. And again, that's been a big shift compared to the historical notion that a man is just kind of universally fertile across his lifespan.
Dan, thank you for the, as always, excellent lecture with the update. So 50%, involves the male. I've heard that statistic, when I was a medical student. So do you think, number one, there's an issue, since you keep saying it, do you think there's an issue with people knowing it? And if so, why?
Yeah, there's a much better, so to answer your question, knowledge gap, right? So there have been a lot of very good and very effective efforts by both the AUA and other advocacy groups just to raise awareness of the male factor. And we've seen this not just specifically in male fertility, but in men's health in general. And so there have been many efforts in the last 1 to 2 decades of improving the awareness of the fact that, yes, men have an important role in the reproductive outcomes for couples. There certainly is more work to be done. But anecdotally, I'm seeing fewer and fewer couples where the man has not been evaluated in a timely fashion. So at least locally, we've done, I think, a pretty good job of reaching out to our colleagues in primary care, our colleagues in OBGYN. But your question also gets to access to care, which is a big thing, both locally and across the country, right? Not everyone across the country has access to urologists. Not everyone across the country has access to urologists who are interested and trained in male fertility. And many times that couple's first step into the infertile world is through reproductive endocrinology. And so that's why it's been great for me, at least, to observe the collaboration between the AUA and the American Society for Reproductive Medicine. About 10% of the members of the American Society for Reproductive Medicine are urologists. But if you look at the leadership chain of the ASRM, there have been a number of urologists as past presidents, and also members of the sub-societies within the ASRM. So yes, the male factor continues to be present about 50% of the time. But my hope is that those numbers, that only 20% of the male partners were being evaluated, that those numbers will continue to improve over time. Yeah, but it's a great question about access to care, knowledge gaps, and needs assessments for that.
I have 2 questions, Dan, and thanks again for the great talk. The first is along the lines of access. Can you update us on where our region stands regarding insurance coverage for fertility care? Because I know that changes as well with health policy and things of that nature. And then the second question is, when you're seeing these couples, I would imagine that there's a lot of emotion from the couples and in the room. And how do you sort of manage that? I mean, I see a lot of families with cancer diagnoses where there's a lot of emotion in the room, and that can be a challenge to sort of deal with. And same thing, with infertility, I would imagine. So how do you sort of deal with that? And did you have, any specialized training to sort of feel comfortable talking about some of these issues, or was it just something that over time you've gotten, better at?
Yeah, great questions. Thanks for asking those. So the first thing about insurance coverage. So insurance coverage and insurance mandates are state by state. So right now there are about 10 to 12 states that have state mandates for coverage of infertility services. There's actually a nice website that keeps it updated. So yes, state mandates for insurance coverage for fertility-related services, on the one hand, is progress. You also have to look at the fine print in a lot of those state mandates about what's covered specifically or not. But as a segue to your second question, that can be a very stressful part of the fertility journey for couples. The potential costs associated with treatments. And when we see patients in our general urology clinics, and we say, yeah, why don't you go check your PSA or get your Chem7 or your CBC, your BMP. Most of us don't really think twice about checking that box and sending them to the lab, because rarely, if ever, is something like that not covered. Turns out, even though simple blood tests can be extremely expensive, and so those hormones that I listed on one of the slides, each one of those in our system, if you're paying cash, is over $100 each. And so if you're checking those at baseline, that might be a couple clicks on the computer, $800 out of pocket. And you're taking a situation that's already stressful. The couple's trying to conceive, they've not been successful in being able to conceive. It's been going on a while, 6 months, 12 months longer. And then on top of that, you're putting the potential financial stress into the mix. It can be a very stressful time for a lot of couples. So how do we handle that stress, to segue? So I personally feel that I'm very lucky to be working at a multidisciplinary clinic that has a big luxury of having a full-time PhD clinical psychologist who specializes in fertility. Julianne Zweifel, both locally and nationally within the ASRM, she's been a past president of the Health Psychologist Sub-Society of the ASRM. She's a wonderful resource. So I routinely, when I'm meeting couples for the first time, acknowledge that and let them know that Dr. Zweifel is a resource for them, either individually or together as a couple if things are getting stressful, if and when things are stressful. And also, when couples are faced with severe male or female factor issues where they're going to be going into the IVF process, nearly every couple meets with Dr. Zweifel prior to starting the IVF process, just to talk about the potential emotional roller coaster that many of those couples experience. So, but again, not many centers have the luxury of having a full-time PhD clinical psychologist literally right down the hall from where they are.
Yeah, I think that's great that proactively you're kind of addressing the mental health needs of these patients.
Yeah, and it's hard, and your point's a good one. During our medical school and residency training to become urologists, we don't have a dedicated block of how to handle emotions, and so a lot of those skills are learned over time, interacting with patients and couples and families for some of the different things that we all treat in the urology world. But having access to a mental health specialist is quite a luxury, and for both us and for our couples and our patients. Great. Well, thank you all very much again for your attention. Residents, thank you for listening to me in about an hour. In the Resident Education Conference, we'll be talking more about the treatment side, both medical and surgical treatments of male factor fertility in our rec. And thanks everybody for your attention.